At the outset, I thank the PACE team, Dr. Govind, Dr. Madhusudan, Dr. Fani for the excellent conference and for giving me this opportunity. My topic of today is overview of biliary complications after pediatric liver transplantation. And pediatric liver transplantation is one of the most successful transplant procedures with the introduction of living donor transplantation and split liver transplantation and monosegment transplantations. However, Sir Roy Callan said that biliary reconstruction is the Achilles heel of liver transplantation. It still holds good as today now. Most of the cases, the biliary for the pediatric liver transplantation, the indication is end-stage liver disease due to biliary atresia. And these biliary complications, although they don't cause much mortality, they cause morbidity, affect the quality of life with recurrent invasive procedures, and some may end in retransplantation. The endoscopic interventions made a revolutionary progress in the last 2 decades with minimally invasive armamentarium along with the percutaneous interventions. They became the first line of treatment, displacing the surgical intervention as a second backup option. And coming to, as you all know, from the morning, there are different types of pediatric liver transplantations, living donor, cadaver, split liver, monosegment, etc. However, I would like to bring to your notice that the living donor liver transplantation is associated with overall high incidence of biliary complications as high as 29%. And bile leaks are also more and strictures are also more. And I would like to bring to your attention that right duct grafts, the leak is 15% and stricture is 18%. And coming to the biliary complications after liver transplantation, the temporal presentation. Within 30 days, that is the early, the complications are divided into 3 categories basing on the etiology and the temporal presentation. The early 30 days are mainly due to surgical technique problems. They are mainly the bile leak, anastomotic stricture. And in the later dates, after 3 months, the most of the complications are anastomotic stricture, non-anastomotic stricture, etc. However, after 1 year, the complication rates, they keep on coming down and most of them they present with strictures only. And these are the risk factors. They vary from the donor, technical factors, surgical techniques, and the recipient factors. I would like to bring to your attention that elderly donor, donor with steatosis, and obese donor, and when gender mismatch, they are associated with biliary complications. Again, the graft procurement. When the cold ischemic time is more than 12 hours, the incidence of biliary complications is as high as 30%. And the warm ischemic time, if it is more than 70 minutes, for each minute there is increase of 6% of biliary complications. And the secondary surgeons who know very well about the surgical risk factors involved in the pediatric liver transplantation and the recipient status also play a major role in the incidence of biliary complications. And coming to the biliary complications in general, in the donor bile duct, the most of them are the ischemic type biliary lesions, that is the non-anastomotic strictures, and at the anastomotic level, the biliary duct stenosis. And in the recipient biliary system, they more develop the stones and the ampullary dysfunction. And coming to the etiology, most of them are major due to hepatic artery thrombosis, that is the macroangiopathic lesion. And second is the microangiopathic lesion, where I already discussed the cold and warm ischemic times, they play a major important role. However, mind you, you have to play a role of know about the immunological aspect in developing the development of biliary complications. These are the classification of biliary complications: the bile leakage from bile leakage, anastomotic stenosis, post-transplant cholangiopathy, that is most commonly denoted akin to non-anastomotic stricture, biliary cast syndrome, and biliary diseases secondary to hepatic artery stenosis, thrombosis, and recurrence of the primary disease. However, I am not dealing with the biliary leakage, and my next speaker will talk on biliary leakage and biliomas. So, I will go directly into anastomotic strictures. And these are the incidence of biliary complications. They vary from 6 to 10%. The anastomotic and non-anastomotic strictures are more common, followed by bilioma. And why there is biliary injury, biliary complications? One thing we have to remember is the biliary epithelium. There is sloughing of the biliary epithelium occurs even before transplantation. That is the main event. Then this biliary epithelium is regenerated by the peribiliary glands. Once the peribiliary glands are not regenerated properly, there is a great chance of developing a complication. And the biliary epithelium is supplied by the perivenal plexus. So, before the transplant itself, there are changes in the bile duct. Then biliary complications need a high index of clinical suspicion because they do not follow the routine symptoms as in adults, like pain abdomen, change in the biochemical profile, fever, all these are absent. And the intrahepatic biliary radicals in the allograft, they do not dilate immediately. They take 3 months for showing on ultrasound. So, the main key is elevation of gamma glutamyl transpeptidase and ALP. If the serum bilirubin is more than 1.5, it is a very sensitive indicator of biliary complications. And ultrasound scan holds very low sensitivity, as low as 50%. So, if you suspect a biliary complication, the important investigation imaging is magnetic resonance cholangiography with a sensitivity of 95% and positive predictive value of 98%. And the hepatocyte specific gadolinium DTPA cholangiography, nowadays it is very helpful in diagnosing these complications earliest. But however, the non-availability and the lack of therapeutic ability holds them at a lower order. Then coming to the biliary strictures form the commonest complication of biliary post-transplant cases. It is as high as 28 to 32%, but in a DCD patient it is as high as 60%. The early strictures, they are due to technical problems, and the late strictures are due to the vascular insufficiency, inflammation and tissue fibrosis. One of the important indicator is the bile leak. If the patient develops bile leak, the patient, it is an independent risk factor for transplantation. The strictures are divided into anastomotic and non-anastomotic strictures. And as I said, the biliary reconstruction is the major crux of the liver transplantation. And when there is a duct-to-duct anastomotic stricture, which is very common, it increases as the duration progresses, and there is an incidence of 13% at the age after 10 years of liver transplantation. Then anastomotic stricture management is like any other biliary stricture management with standard repeat balloon dilatation, stenting and sphincterotomy. And the role of plastic stents, I want to highlight this. Multiple plastic stents are indicated at the first setting itself in these anastomotic strictures. Then the role of fully covered metal stents. One point I want to highlight is placing a biliary stent above the papilla. In routinely, we place a stent across the papilla, but in pediatric liver transplant patients with strictures, it is better to place the stent above the papilla because when the stent is inside the papilla, the patency is 450 days. This is the fully covered metal stent inside the papilla. Then in the hepatico-jejunostomy patient, with the use of the single balloon enteroscope, double balloon enteroscope and spiral enteroscopes, we can go through the efferent lume and approach the stricture and do the stenting. This is guide wire across the hepatico-jejunostomy stricture dilated with balloon. And the role of percutaneous drainage, there is a talk tomorrow, so I am not going into details, but percutaneous drainage is performed when there is failure of the ERCP or when it is not possible in a biliary anastomosis. Then interventions versus early surgery. Early surgery is better if the patient is presented with repeated endoscopic interventions, and to save the graft, early interventional surgery is better. It have better, especially in biliary anastomotic cases. Then NAS non-anastomotic stricture is applied to a variety of abnormalities you see in the biliary tree, starting from the single, multiple strictures, multifocal, mucosal irregularities, CAS and everything. And another is the ischemic type biliary lesion. This is also common in 5 to 15%. And I want to focus to the surgeons mainly because it is the anastomosis at biliary tree is divided into A, B, C, D. A and B are extrahepatic and C and D are intrahepatic. And C and D are the main critical things which affect the endotherapy. It is very easy to treat the A and B cases, but mind you, in non-anastomotic strictures, there is a combination of strictures. I already told that macroangiopathic, microangiopathic, immunologic injury. I want to mention about the HAT. Early HAT affects, causes biliary necrosis, needs prompt therapy, whereas the late HAT presents as an attenuated form and usually presents as a PSC-like stricture. Then the endotherapy in NAS is not as easy as anastomotic stricture, and the response is very poor. They need more ERCP sessions. The approach is difficult. The intrahepatic radical strictures are very difficult, and it is not so rewarding as like a anastomotic stricture. And this is the main thing. The anastomotic strictures are single, early, short, located at the anastomosis, easy to approach with a very good prognosis with no graft loss. Whereas the NAS is multiple, variable, diffuse, intrahepatic, and the enteroscopic therapy is very difficult, and the graft loss is as high as 20 to 50%. And another important is filling stones in the filling defects. This is like treating any adult patient, but one thing is after the removal of the stones, the biliary stenting is not indicated in these pediatric patients because it will block the biliary duct and it will cause more stone formation. Another is the biliary CAS syndrome. This is a extremely difficult thing to do. It occurs in 2.5 to 18%, and most of the patients, the clearance is can achieve only in 60%, and the retransplantation is as high as 22%. And sphincter of Oddi dysfunction occurs due to the denervation, fibrosis, edema, and treated as in any other person like ERCP, sphincterotomy and stenting. Another is orphan duct syndrome. This is pertaining only to the PDLT patients. This is a type D leak, and this is very refractory to treatment, needs to be done by percutaneous interventions. Coming to the recent advances, one small few minutes, with the use of the steerable ERCP cannulas, and there is a new balloon which they use in coronary artery disease. The peripherally cutting balloons, if you use the peripherally cutting balloons at the anastomotic stricture, they are very effective in this. And another is use of the long stents like the Jolin pancreatic wedge stents. They are very long with side holes. If you use these side holes stents in these patients, they drain the biliary tree. And the of course, the bioabsorbable stents are there. Coming to the recent other advances is the use of spyglass endoscopy, where you can directly visualize the anastomotic stricture and decide if there is erythema and edema, it responds to endotherapy. If there is sloughing and ulceration, they need a long-term treatments. And another is the cholangiography guided steroid injection into the stricture. And another is, I want to stress on the prophylaxis of these biliary complications, because it is may end in graft loss. So, implantation of the internal biliary stents across the anastomosis, like the Archimedes stent, which they use in the pancreatic duodenectomies, they are helpful in preventing the anastomotic strictures across the biliary system. This is the conclusions. The biliary complications are high because of the complexity and vulnerability of the biliary anastomosis, especially in pediatric transplantation patients. Timely management saves a precious graft. Bile leaks and all the early biliary complications, they need to be followed very carefully, because all these patients, they have late biliary complications. Percutaneous and surgical modalities are reserved only for a selective group. And prevention is better than cure. So, early use of the biodegradable stents to save across the biliary anastomosis saves many precious grafts. Thank you so much.